All right. So good afternoon, class. So today we will be doing the discussion about brief psychotherapies. And for this, there are empirical studies of brief therapy. Okay, for the brief therapy, can you see the slides? Okay, for the brief empirical studies of brief therapy, these studies include dose effect relationship, a consumer survey, and meta-analysis comparing the relative value of different therapies. So there are a process and outcome studies of each form of brief therapy. Number one is the dose effect analysis. On the dose effect analysis, in sum, it is probably takes between 8 and 16 sessions for 50% of patients to improve and about 20 sessions for 75% of patients to show significant gains. It should be noted that change in these studies usually refers to symptom improvement or to feeling and functioning better, but does not include other kinds of outcome measures valued in particular by experiential and psychodynamic therapies. And for the second one, on the process, we have what we call the survey of consumer satisfaction. On this process, an examination in consumer report survey of client-reported outcomes shows that the degree of felt improvement and satisfaction rises rapidly until 3 to 6 months of therapy had been experienced. So that's the two process, and we will be discussing the third process. On the third process, okay, so for the third process, we will be discussing about the meta-analysis. What is meta-analysis? On the meta-analysis, it carried out by Wampoyd during 1997, a bona fide treatments that the great majority of them short-term were compared. There seems to be a consensus that brief therapy is probably unsuitable to patients with more severe disturbances, including some of the personality disorders, and there seems to be a consensus that brief therapy is probably unsuitable for patients with more severe and disturbances, including some of the personality disorders. So after this, the empirical studies of the brief therapy, we have what we call the 6 form of brief therapy. And what are these? Number one is what we call, okay, before we do that, okay. So the 6 forms of brief therapy, there is a brief historical introduction. Number 2, selection criteria, including diagnosis or problem related. And number 3, techniques of the therapy. And number 4, the theory change. And 5, research supporting the approach. And 6 is the future direction. We start with the oldest of the therapeutic traditions or psychoanalytically based therapy. So for this one, we have also what we call a brief psychodynamic therapy. What is this? The brief psychodynamic therapy, or what we call BPT, applies the principle of psychoanalytic theory and therapy for the treatment of selected disorders within a time frame of roughly 10 to 25 sessions. And for this, brief dynamic therapies rule out those patients whose severity of disturbance precludes their ability to engage in an insight-oriented therapy. That include also serious suicide attempts or potential, current alcohol or other drug addiction, major depression, poor impulse control, incapacitating chronic obsessional or public symptoms. And in terms of DSM, these include the adjustment in disorders. So for the selection criteria, there in general for selection criteria, Brief dynamic therapies rule out those patients whose severity of disturbance precludes their ability to engage in an insight-oriented therapy, or who need more time to work through their problems. Although it is difficult to generalize because the different models set narrower or wider criteria. The following sections describe the general indicators in favor and against recommending BPT. So for the psychotherapy indications, we have what we call many of the diagnostic criteria stated previously are descriptive or static, based largely on the patient history and garnered from the initial interviews. And for this, interpersonal or motivational indication allows his or her relationship predisposition to be played out in therapy relationship and collaboratively examined. And on this process also, this determine the extent of previously listed characteristic. Now, there are techniques of therapy. For the techniques of therapy, okay, added for the interpersonal or motivational indication, the patient is sufficiently comfortable with his or her feelings or behavior to seek help via psychotherapy, has basic trust in possibility of relief from distress through the therapist-patient relationship, and is willing to consider conflicts in interpersonal terms and to examine feelings, can relate to others as separate individuals, allows his or her relationship predisposition to be played out in therapy relationship and collaboratively examined, and is motivated and determined by the extent of previously listed characteristic. That includes the interpersonal or motivational indications. Now, we have what we call the techniques of therapies. What are these? For the techniques of therapies, we use a central focus more actively in brief therapy than in open-minded treatment. In this, there is a use of a time limit brief treatment. The time limit is understood to accelerate the process of psychotherapy, and the role of determination activated at the start of the treatment. And active inquiry refers to any variety of techniques aimed at accelerating the therapeutic process to make it possible to accomplish the goals of psychodynamic importance. And the goal setting of the techniques of therapy is to link the use of central focus as well as to the limit and centrality of termination. So what are the different types of these therapies? Number one is what we call the cognitive behavior therapy. On this CBT or cognitive behavior therapy, it has been traditionally utilized as a short term for a wide range of emotional disorders and problems. This marriage between cognitive and behavioral approaches has largely occurred due to their common emphasis on targeting symptoms and problems, and utilized and shown to be a wide range of psychological problems experienced by children and adults. So cognitive behavior therapy, or what we call CBT, attempts to empower patients, and thus there is an emphasis on providing them with skills to offset their negative emotional states and dysfunctional behavior. Another theory of change, on the theory of change, it utilizes strategies to change cognitions. Number two, on the theory of change, this includes central to the cognitive model of emotional disorder. Third, mechanism of action of cognitive behavioral treatment is change in reinforcement. And the theory of change for the above stated cognitive or CBT, they demonstrated substantial efficacy in the treatment of substance abuse and dependence, obesity, binge eating, irritable bowel syndrome, encompasses childhood anxiety, female hypoactive sexual desire, sex offenders, borderline personality disorder, family intervention, and social adjustment in schizophrenia. So another type of therapy is what we call the brief family and couple therapy. What is this? This is differ in terms of their dominant views of what maintains problems and what needs to be done to resolve them. In terms of patient selection, what is generally more important than standard psychiatric diagnosis is the eyes of family, and the couple therapies is the problem maintaining role of people involved in the lives of the index. So on this brief family couple therapy, the theory change or the techniques of this therapy establishes a therapeutic focus, meaning or the meaning of use of time. In addition to present-oriented techniques and an emphasis on family behavior patterns centered a problem on focus. Okay, and for the brief experiential therapy, we have another one for this is what we call the brief experiential therapy. There are three distinct therapeutic traditions to lead to the development of brief experiential therapy. These three are what we call, number one is the client-centered, number two is Gestalt, the client is view discovering that which leads to change, and number three, the existential concept of personal responsibility is paramount. And for this, we also have a prominent exponent of process experiential therapy, consider BET to be suitable for patients with mild to moderate distress and symptoms. And potential clients should also be able and willing to focus in their inner experience and to express emotions. And another one that includes on this therapy or the techniques of therapy, this emphasize or express empathy and genuine pricing. Second, it facilitates mutual involvement in goals and tasks of therapy, facilitate optimal client experiential processing, foster client growth and self-determination, facilitate client completion of key therapeutic tasks. So for the basic exploratory tasks, there are two basic exploratory tasks. There is an active expression task that intended to bring hidden emotion to the fore. The second one is the interpersonal task that include a therapeutic relationship characteristic by empathic attunement. And for this, on the theory of change of the above, the theory of experience-centered therapies were covered in detail in Grandberg and Van Balen. Emotion schemes are structures that serve as the basis for human experience, and analysis of the studies that had wait list controls showed a similar advantage of treated over untreated clients. So what are the future directions? On the future direction, experimental treatment has been rising to the challenge by studying the kinds of therapies interventions that are necessary to treat a variety of disorders within this tradition. And one approach being adopted within the experiential tradition is extensive single case to track changes in key clients' issues across the course of the therapy. Now, another techniques of therapy is what we call strategic therapy. And this is a brief problem-focused psychotherapeutic approach developed by Palo Alto Brief Therapy Group. So the treatment was not focused on understanding psychopathology, but rather on solving as they crop up, considered appropriate for the entire range of problems for which people seek psychotherapeutic treatment. On this strategic therapy, the techniques of this therapy define the complaint in specific behavioral terms, set minimum goals for change, investigate solution to the complaint, formulate ironic problem solution loops, specify what length of time will look alike, and understand the patient's preferred views of themselves, the problem, and each other. And also, it used patient position to interdict problem-maintaining solutions and nurture and solidify incipient change. And if the problem of maintenance behavior can be reduced or eliminated, the problem will be resolved, regardless it is nature or origin or duration. The treatment outcome data supporting its efficacy must be generated. Identifying patient's problem most likely to benefit from strategic therapy would support its use in such cases in which simple parsimonious therapy may be the first line solution. So the last one is what we call the brief integrative eclectic therapy. On this particular therapy, that include the large majority of practitioners are eclectic or integrative in practice. Eclecticism refers either to technical eclecticism or to prescriptive machine. So theoretical integration attempts to encompass different theories and the techniques deriving from them in one coherent theory. The suitability criteria tend to be minimal and less stringent. Typically, in brief integrative eclectic therapy or the BIEP, only the most severely disturbed candidates are excluded. Okay, and the use of this, the techniques of therapy for that, the BIEP, there are no techniques that are unique for this. The 5 forces described are losses, developments desynchronized, interpersonal conflicts, symptomatic presentation, and personality disorders. So the early beginnings of the group psychotherapy originated in America in 1905 and was first conducted at Massachusetts General Hospital by internist. The name is Joseph H. Pratt Moreno, and may have coined the term group therapy in 1931. Although he never formally conducted group therapy, Sigmund Freud called attention to group psychology in group psychology and analysis of. However, early in the study of group, a fear of possible negative factors surfaced, voiced not only by Freud, but also earlier by Libon in 1920 and others. So when conditions are favorable, groups enjoy the power that comes from contagion. So contagion is a process by which members of a group are pulled into an activity in which they might not engage by themselves. So for the group therapy, it was already originated in America in 1905. So it was first conducted at Massachusetts. That's a General Hospital in Massachusetts. And it was first conducted by an internist, a doctor named Joseph H. Pratt Moreno, that had coined the term group therapy in 1931. So for the group therapy, The first psychiatric hospital was established in Europe and at the end of the 18th century and soon were followed by the handful of institutions in United States. And during the World War II, groups were used in several military hospitals. And at the Northfield Military Hospital in England, Bayonne, Fox, Eshrel, and Maine in 1965, they introduced the idea that psychiatric unit in its entirety is a group and such it has therapeutic benefit in all its parts. So what are the history of inpatient group? So the history of inpatient group includes psychodynamic theories, classical analytical, object relation, self-psychology, intersubjective theories and relational theories, related analytical theories, the Gestalt theories, the cognitive behavioral theories or CBT, the non-analytical theories, and the transactional analysis. We have the principles of group psychotherapy or the basic theories. Number one is what we call the psychodynamic theories. On this is the most current analytical theories defined by psychodynamic umbrella as consisting of four major branches. The four major branches are classical theory, second, object relation theory, third, the eco-psychology, and the fourth one is the self-psychology. Now, on the principles of psychotherapy or basic theories, that includes also what we call the classical analytical. This emphasis on libido and aggression finds expression in the unconscious forces that propel the group as a whole along its epigenetic trajectory. In this model, the group develops along the same epigenetic trajectory as the individual. We have also the object relations. This finds in groups as a natural environment for the projection of internal part objects onto the other people in the room. And self-psychology is self-psychologists recognize the mirroring and empathic possibilities of committed members who can serve as self-objective function for one another. And for the related analytic theories, this existentialist depends on the group to explore, verify, and accept the individual's personal myth and intentionality in the world as they contribute to the individual's self-authenticity. So for the Gestalt theories, the theory of Gestalt therapy is defined by the two central ideas. First, the proper focus of psychology is the experiential present moment. Second, it is only possible to know the self in relation to other things in the interactive field. We have also the transactional analysis, and this includes or divides personality into three phenomenological components or ego states. Number one, colloquially termed parent, adult, and child. Non-analytic theories, a host of other theoreticians have contributed to the field of group psychotherapy. Some of them include the cognitive behaviorists, the Gestalt theories, transaction analysts, and the decision therapies. On this cognitive behavioral theories, it includes a behavioral group therapy. Some structures insist that are similar to those in their or in other orientation. That also includes the healing factors emerge and operate in all groups, factors that can be brought into play to allow the individuals within the group to grow and develop beyond the constrictions in life that brought that person into treatment. So what are the therapeutic factors common to all group psychotherapy. Number one, the group goals. These goals include offering a supportive community to the patient, relieving symptoms, increasing self-esteem, and freeing the patient to move forward with their life goals. And the goals of the open-ended psychodynamic therapy group is to change, or character change is the main goal. And standard target for psychoanalytic groups in particular is the reawakening of early neurotic and logical problems in the transference that emerge in the clinical hour. For all people, character problems are outside the patient's awareness, syntonic, that is perceived as who am I when brought into awareness, resistant to change even when the patient wants to make such a change, repeated compulsively until worked through, that is, they are robbed of some of their power in each experience of successful change to better alternatives. Difficult to change without strong motivation to overcome psychological inertia. The tide of group belongingness provides the necessary motivation, and the group becomes a laboratory for trying out new behaviors in supportive contexts. Feelings about the self and others become less troublesome. So what are the goals of cognitive behavioral group, or the CBG? On these cognitive behavioral groups, what is the symptom-specific groups? The goal of such group is to provide support and information embedded in socially accepting environment. For the self-help groups, these groups have become a major source of recovery and cure, and they illustrate the value of community and the group cohesion for managing range of human distress. And what are the support groups of various kinds? Number one, the techniques of conducting an open-minded group therapy. This develop a contract that gives meaning and structure to the work in the group, building the alliance for both before and in the group, interviewing the patient to screen for the appropriateness of group treatment, and preparing the patient for working in the group. There are sources of conscious and unconscious data. These are the primary data in analytic treatment, as basically what the patient says, what he or she does, and what he or she characteristically is. Number two, common phenomena in psychodynamic group therapy. This includes that members contain the projection of one another. The work of the analytical group. On the work of the analytical group, we have the organizing and conducting an open-ended psychodynamic group. On this psychodynamic group, the composition in such a group ideally consists of people with fairly homogeneous level of ego development. The leader should try to develop a clear set of shared group agreements relative to the time, attendance, fees, and other external consideration, such as the third-party payer intrusions in the work. And the psychodynamic clinician should avoid actions that interferes with the flow of the patient associations. The clinician in this model should strive to maintain a neutral stance toward the material, being careful to analyze. We have the activity, inactivity, and neurality. And this, the group therapy sets the stage for the work of the group by developing a climate that is respectful, avoid undue shaming of any one member by underscoring the universal quality of all human pain. So working with shame in groups. This is a challenging task for the analytic group therapies have to do with maintaining a clinical equilibrium in the face of his or own exposure to the contagious forces of the group. Fear of malpractice suits has added anxiety to already overburdened practitioners. So what are the countertransference? Pressure in the analytic group. Number one, the primary focus of the stay is that ameliorating the patient's psychological distress. Second, I check every minute or may not be permitted to leave the unit. In any event, must ask permission to do so from someone with a key. And for the inpatient group therapy, this include educational group. This group typically include information and medication, diagnosis, and condition encountered by the patient. Second, the activity groups. This usually involve some kind of physical action such as craft, project, music, cooking, or calisthenics. So third one is the behavioral groups. This include skill training in areas such as communication, stress, management, addictions, and management of self-injurious behaviors. Third, or the last is the psychodrama. And this involves the enactment of people conflicted relationship in a stage using other patients and staff to play the parts of the various members of the patient's social world or psychotherapy groups. What are the types of inpatient groups? So the types of inpatient group is what we call, number one, psychotherapy group. These are most analogous to psychodynamic outpatient groups and may occur several times weekly. Second, the change in model. The change in model, such as approach, can easily be seen as lending support. However, irrationally to the idea that medications are the only real benefit being offered a person who is hospitalized, and the goal of inpatient psychiatric groups, and the goal of this is the goal of treatment within the hospital is to ameliorate unbearable pain. And for the last topic, what are the types of inpatient group? Anyone who works in the inpatient unit in a clinical capacity may run a group and hospital as varied to the structure and organization of these roles. Psychiatrists and psychologists, social workers, occupational therapists, nurses, counselors, and trainees all may lead groups. Who leads the inpatient groups? Number one, maladaptive behaviors are the target of the intervention. Second, the length and stay of population, unit philosophy, and unit structure all contribute to the overall atmosphere of the hospital work. So what are the so that's the last slide that we have for the group psychotherapies.